I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. Welcome to the NEI podcast. On this show, I sit down with renowned mental health care experts from a range of diverse backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions. In this episode of the NEI podcast, I have here with me today Dr. Linda Gask. She is a psychiatrist, researcher, clinician, and patient in the field of mental health. And it is such a privilege to welcome you on our show today.
Thank you.
We are discussing the importance of caring for your own mental health as a mental health provider. My first question for you, Dr. Gask, is what led you to pursue a career in mental health?
When I was a medical student, and in the UK, we don't do a degree before doing medicine. We go straight to medical school at the age of 18.
Mm-hmm.
And when I was a medical student, I felt more stimulated and interested by the time I had in psychiatry than in anything else. I just found it fascinating. I loved that I could spend time really getting to know a person,
right,
and find out their story. And I just felt more at home there. And I seemed to have an affinity for being able to kind of find out what about a person, sit down and listen to them. And I just really enjoyed my time in psychiatry.
Oh, that's wonderful. Why are you so passionate about mental health care in the primary care setting? I know that you've written some books in this area, and it seems to be a mission that has been very important to you.
Yes, I think it has. It was the very first research I started doing as a junior doctor in psychiatry, I guess what you'd call a resident.
Mm-hmm.
And in my own family, members of my family had mental health problems.
Mm-hmm.
And I was really aware of the power of the primary care practitioner, the family doctor,
Right.
in getting access to care for people.
Mm-hmm.
And that so much depended on who they referred to, because in the UK, you can't refer yourself straight to a specialist. And so they were very powerful. And I learned that they care for about 90% of mental illness, which is not unusual around the world. They have the biggest burden of mental health care, and yet they seemed in many ways so not always very well supported or very well prepared to do it.
Right.
And so I spent time in my first research project going out and spending time in their practices and talking to them and trying to find out why people had been referred, what happened after they'd been seen. And it just became something that I realized, that it wasn't something that a lot of people were doing, particularly in psychiatry. And there was an opening for me there in terms of doing further research, which at the time I took because I wasn't ready to go into full-time clinical practice. And so I started in research in that area. And as time went by, I think I just got more and more interested in it.
That's great. Yeah. And I think what you touched on is so important that, primary care professionals are seen, to have to focus on mental health issues. And many of them feel unprepared, both in our country as well in the United States. So I think you're right. And it's such an important issue.
Yes, I did spend some time in the US doing a fellowship, Harkness Fellowship in 2000. And I also interviewed quite a lot of family doctors in the US. And that was fascinating, having spent time with them in the UK. And discovering that in many ways, they're just the same people. They have the same issues. They're just working in a different system.
Right.
They have different paperwork and they have a lot of it. But it was lovely to find out they were really not very different.
When did you first experience your own challenges with mental health? Can you share a little bit about that with us?
Yeah, I think it was when looking back, I realized that I had quite severe anxiety as a teenager, particularly around examinations. But I think the problems really began when I went to medical school.
Mhm.
And again, some of it was to do with examinations, quite severe anxiety, but also I had problems with leaving home. I'd been very glad to get away from home because things weren't that great at home, but I also felt lonely and found it difficult to settle in because I did come from quite a different background from a lot of other medical students. I came from quite a working class background. I had problems and I sought help really from quite early on. I think probably the first or second year I was there. But the major problems came in my final year, which was really terrible exam-related anxiety, and I got quite depressed as well.
Wow. How did your personal experience with depression and anxiety impact your professional career in mental health?
Well, I had periods of time off sick during my professional career. In medicine, you have to take exams, and I had quite severe professional examination-related anxiety. I also had problems with service management in getting into battles about things, which I think that's just me, but I think in any system that you work in,
Right.
when you're concerned about patient care, you get into battles with managers, and I did. And I also had my marriage broke down, and a lot of these things, I actually, from the age of 24, 25, I became really quite depressed. At the same time, my father had also died, and I had a delayed grief reaction from his death. So I went into therapy quite young, really. I was 28, and I went into longer term psychodynamic therapy, which helped me a great deal at that point to make changes in my life that were really necessary to help me to make difficult decisions about how I needed to change my life in order to be able to survive, really.
Right. Wow. Your story is so, inspiring because I think it provides, people who are patients with a deeper understanding as you being their provider. I think that there's a deeper connection there, perhaps, and it's really inspiring.
Yes, some people say, do you think it made you a better doctor? I don't know, but I think I do know what it's like to be a patient of a psychiatrist. I do have some understanding of that. I know what it's like to be on the receiving end of the questions.
Right.
And to sit in the chair on the other side of the room. And so I think maybe I have more awareness of what it's like as a patient. I don't know whether that makes me a better doctor, but I think it may have done.
Right. What made you want to retire, and what happened with your health shortly after your decision to retire? How did this transition impact your mental health?
Well, I had a number of episodes of depression, despite staying on medication. And I went onto medication after I had to go onto it. Therapy alone wasn't enough. I wish it had been, but it wasn't. And I got much more severely depressed. And medication kept me reasonably well, but it didn't stop me having relapses. I think they would have been worse had I not been on it. And that's very much what my psychiatrist said at the time. But I realized that it wasn't going to get any easier. And I really felt if I don't stop soon, I'll just have another episode. And I really felt the need to get away from the pressure of work. I think it wasn't so much the pressure of my clinical work. It's the pressure of being an academic who in a department, I'm sure you'll understand that. And, having to get grants and all of that at the same time as trying to care for patients. And it's very pressured being a clinical academic. And it changed during the time that I was an academic. And my husband was saying, you can't go on putting so much pressure onto yourself. So I made a decision that I was going to go at the age of 58. And I started to not take on PhD students, and people around me honestly didn't believe I would go, but I did. And it was the right thing to do.
Right.
But within a few months, I discovered that I was much better in my mood, although still struggling at times.
Okay.
And then I discovered I had some quite serious physical illness. I have something called autosomal dominant polycystic kidney disease, which is an inherited disease, most likely, although it can be due to a new mutation. I was diagnosed with that about 6 months after retiring, which was a real shock because I had viewed this as being, I was going to lose weight, get healthy, change my life. And then I discovered that I'd had this all my life. It was just developing very slowly.
Right.
I have the slower form. There's a faster form that results in you having to go on dialysis in your 30s. And there's a slower form that I have. So that was really quite a shock. And despite the fact that I was pretty well in my mood at that point, that kind of knocked things a bit.
Yeah, understandably. Yeah. Can you share your thoughts on the mind-body connection when it comes to mental and physical health? So related to what we were just discussing.
Yeah. I think what really concerns me about healthcare provision is the way the two get separated. It's bad here. I think it has its problems in the US as well. I know from, my own work there and visits that people, when you have serious physical illness, you're at risk of mental health problems as well. People who have diabetes get depressed. People who have chronic kidney disease, like I do, have a much higher risk of getting anxiety and depression. People with obstructive airways disease, have a high risk of panic and anxiety. And then the other issue is that if you have severe chronic mental illness, a diagnosis of schizophrenia or bipolar disorder, you've also got the risk of dying, 20 years younger. And I think that our providers are not very good at working together. And they tend to think, if you've got physical symptoms, they'll rule out the physical symptoms, but they're not very good at saying, maybe this person's got some physical health problems and emotional problems. It's always either or. And they don't work together very well. We know that an awful lot of people who get anxious or depressed present, first of all, with physical health problems or physical symptoms. But they see a doc and he rules out it's heart, or he rules out that it's, something to do with your body. And maybe very often it's both. And, I have my kidney disease, but I also have ongoing mental health problems. And I now have some cardiac problems as well. So I have numerous things wrong with me. And I think one of the reasons I think primary care is so important is that a good primary care doc can actually take all of those into account and actually think, well, what is this preventing you doing as a person, rather than putting too much emphasis on, when you go and see a specialist, they tend to only be interested in one particular disorder.
Yeah.
I don't know if that makes sense, but that's my kind of, I really value a good primary care doc for that reason.
Absolutely. Yeah, I do. I think that we see that breakdown here as well between physical and mental health. And it would be so amazing if there was a stronger integration between the two.
It would.
One theory that has emerged from research has to do with a connection between the inflammatory model for depression, a connection between inflammation and its impact on the brain. How has this influenced your own personal journey with depression?
Well, it's interesting you should say that, because I had chronic physical symptoms, which I thought was an infection. No infection could be found. And then I had all sorts of other things go wrong. And I ended up in hospital with sepsis.
Wow.
And I was really unwell. And my mood had been very difficult to improve for about a year or two while I'd had those physical symptoms.
Mm-hmm.
And when I was treated for the sepsis, I had an infection and that got out of control and that caused the sepsis. And when it was treated, everything improved. Not only did my original physical symptoms improve, but my mood improved as well.
Mm-hmm.
And since then, my mood has been considerably more stable. And I think we fail to take in, I think when my own psychiatrist who's done some research in this area, he wasn't surprised. I mean, he said people who are prone to depression, which I certainly am, I think I've got a family history of mental health problems. Chronic inflammation can be important in recovering from depression.
Mm-hmm.
And I had problems with my mood throughout that period when I had unexplained physical symptoms.
Right.
And it's kind of I think it's kind of strange, really, and odd in that I spent a lot of my working life researching medically unexplained symptoms. And then I ended up with a medically unexplained symptom, which I was convinced was real. And it did turn out to be real. And so it's kind of made me, I guess, more suspicious of people who once again say something psychological,
Yeah.
I think it's really important that we keep our minds open. But going back to your original question, I think inflammation may well play an important part. I think we just don't know how much yet, and we don't really know how that will lead to effective treatments. But the indicators in my bloods were showing evidence of that it took them quite a time to come back to normal after the sepsis, which to me indicated that things had been abnormal for some time.
Mm-hmm.
They did not spring back.
Right.
And I think I'd had chronic inflammation for some time.
Yeah. Yeah. It would seem so.
Yeah.
What is your view on depression, and why do you think that there's still stigma that surrounds depression and anxiety?
Well, I don't think there's one thing called depression. Probably did us a disservice in terms of creating major depression, because I don't think depression is a single thing.
Right.
I think it's an end process that may have numerous different causes. Some of them, for some people, depression seems to be more biological. For other people, it's often the social factors that trigger it off. My kind of working way of seeing it has always been to think in terms of underlying vulnerability and all the things that make us vulnerable, our family history, our genes, our early environment, and then to think in terms of triggers, life events. I think there's absolutely no doubt that life events trigger depression off.
Yeah.
And then there are things that keep that depression going. And for me, work pressure was something that kept it going for a long time. But those things might well be biological as well, like having chronic physical illness or disability or aging or all sorts of things. Aging's one of the things that makes us more vulnerable. So that vulnerability stress model is the way I understand depression. So I really do kind of work from a sort of true biopsychosocial perspective. I guess that's the way I was trained, but I just find I find the sort of narrow biomedical view unhelpful when thinking about the world. And it doesn't fit my own experience either as a patient or as a doctor. I think you have to have a broader view. So I've always had that view that, one person's depression is not necessarily the same as another's. And anyone who's coming at you with a single theory to explain it all is probably wrong. So Absolutely. That's the way I see it. And depression and anxiety overlap considerably. I don't see them as really separate. I see them as overlapping. The commonest kind of problem in British primary care is anxious depression. People have symptoms of both. So when you give the doc guidelines for depression and guidelines for anxiety, that's not always helpful because we really should be helping him to treat mixed depression and anxiety.
Right. Wow. Why did you want to write The Other Side of Silence?
I spent a lot of my working life writing research proposals and writing up research papers.
Mm-hmm.
And I became interested in writing because it was something I'd always wanted to do. And I started writing as a hobby after one of my periods of depression.
Mm-hmm.
And when I started writing memoir, I enjoyed doing that. And I thought, I have a story to tell about what's happened in my life. But I found that when I told my story, my patients' stories were there too. Because I think when you're a doctor, you can't get away from thinking about the stories that patients tell you.
Mm-hmm.
And I began to realize that my story had tremendous overlap with my patients' stories, that in many ways, the things that we faced, because I specialized in treating a lot of women, many men too, but 2/3 of my patients were women. I was really working with people who were experiencing the same kind of vulnerabilities and stresses that I had experienced in my life. So I wanted to write that to demonstrate that we really weren't so different from patients, that all of these are very common. And I was really concerned about the stigma amongst doctors, particularly my own profession, in talking about mental health, because at the time, it has improved, but in Britain at the time, doctors simply weren't talking about it very much.
Right.
I remember going to the American Psychiatric Association and going to a session where doctors with bipolar disorder were talking, and Kay Redfield Jamieson was there.
Yes.
And then thinking that would never happen in Britain.
Oh.
I think it would now, but we were simply not being open about having had the same kind of problems. And I really wanted to do something about that stigma.
That's so inspiring. I love that. What is the main message that you'd like readers to take away from reading your book?
I think that doctors are human too and go through the same kind of things that everyone else goes through in their lives, and that there is always hope.
Yeah. You
may not feel like there's any hope at the time, but that's because of the way that you're seeing the world. And having someone there who is with you on that journey, either as your own therapist or as your psychiatrist, a good therapist or doctor should be someone who holds on to that hope for you and who can see how things could be different. And that was really the role I think I tried to play with my patients.
That's so powerful. I love that. I love that. What has your own experience with therapy been like? Can you share what it was like?
Yes, I had quite a lot of psychotherapy. I had three periods of psychodynamic psychotherapy, one of which was really quite psychoanalytic in style, and which I didn't find very helpful. But the other two I did find helpful. I think the therapists helped me to make sense of how my past was still influencing the present. And that was important for me. I also had a period of cognitive behavior therapy, and that was entirely different. It was very much about learning how to live in the present and to deal with everyday problems. And I found it, I think the therapist I had was the first person who I'd been able to talk to about the way my mind worked and the way my thinking worked. And he seemed to understand exactly what I was talking about. I think if I'd have been offered CBT first, I wouldn't have found it helpful, because I think that I had things that I needed to sort out to do with my relationships.
Right.
And I think that's really important. You know, about half of people who are offered CBT don't find it helpful. And I think for me, it's about finding the right therapy for the person at the time in their life that they're at.
Right.
And that order was right for me. Each of them were, they were entirely different, but they were helpful in their own way. The more analytic style psychotherapy, I found the silence of the therapist really hard to tolerate. And I wanted a more humanistic style of therapy. And the other two therapists I had were certainly more capable in that way.
Mm-hmm. Mm-hmm. Wow. It's so interesting to hear your perspective on this, from a patient standpoint, but also as a professional.
Yeah.
What is your most recent book, Finding True North, about?
Well, when I retired, I came to live part-time in Orkney in Scotland. The Northern Isles are the islands off the north coast of Scotland, and they're quite sometimes they feel kind of Scandinavian. These islands belonged to Norway until the 14th century, and there's a strong Viking heritage. And I came to live here. I bought a house. I really thought, this is where I'm going to have to really kind of try and sort myself out once and for all, to do all the things that I've been telling my patients to do for years, but not always been very good at doing myself. And so that's what the book is about. It's about trying to find your way through ways of coping with the world, looking at things like mindfulness and taking more exercise, coming to terms with your past, learning to lead your life in a different way, really thinking about whether or not you can let go of certain things for once and for all. And I've always been a traveler. There's quite a bit in the book about travel and about trying to make sense of the world through travel. But it's very much about finding a place where you feel most at home. Right. And what home actually is. So it's a book about recovering rather than a book about ongoing care. It's a book about living with the person that you are. And so it's different. In many ways, it's more personal than my first book. But it was a book that was very much born of being here on my own and looking out of my window, as I am at the moment, at a landscape, and trying to find out how I was going to live with myself. And yes, it is different. My patients came into it, but I guess less than the first book. I hope anybody would find it helpful in terms of trying to understand how to recover from depression, because that's really what it's about.
Thank you so much for sharing that with us. And all of your books are, I think, very inspirational, especially to have your valuable perspective from both sides. And so that takes me to my final question here, which is, what is your advice for mental health professionals and medical professionals when it comes to prioritizing their own mental health?
I think it's so very important to remember that you're not irreplaceable. One of the rabbit holes that you go down as a doctor and as a health professional is that you become completely absorbed in your work. It's very easy, if you're a perfectionist, and many of us are, to become completely bound up in your work, to get all of your self-esteem from work, to find all sorts of reasons to spend far too many hours at work, and almost to think that it couldn't manage without you, that you're the only person that can do it. And you're not. And the more that you carry on down that route, the more you will make it very difficult for yourself to pull back. And you may actually stop helping your patients because you then do what I did, which was to get very unwell and have to take time off. And I've treated quite a lot of doctors and other health professionals in my career.
Wow.
And one of the biggest things they find difficult is actually stopping work.
Right.
And taking care of themselves. Right. You have to pull back when you aren't well, because it's so easy to go too far and then reach a point where you actually start to cause harm. And you do have to be very careful. I never reached that point because I think I've always been very aware of stopping. And I don't think I ever reached a point where I wasn't capable of working, but I I did listen to other people when they said, you are reaching the point where you're not really fit to be working.
Mm-hmm.
And it's crucial to listen to other people and not convince yourself that you are able to work, because you can't. Other people's perceptions, particularly those close to you, are really important. I don't know if that makes sense, but it is about pulling back from going over the edge. And every week, you read in one of the medical magazines about doctors who've gone too far and taken their own lives. It's a high risk in our profession.
Yeah.
And it's a high risk in nursing too.
Right.
And we have to, when we reach that point, we are no longer capable of doing the best for our patients.
Mm-hmm. Mm-hmm. We
have to pull back and take care of ourselves. I never reached a point where, someone said, you have made a mistake. I never had any complaints made against me, but I think I'm fortunate that never happened. And I know other people who have reached that point, often through mental ill health, through the ways that they cope with it. And then that just makes everything so very much worse and just adds more pressure. You have to pull back before you reach that point.
Mm-hmm. Mm-hmm. Well, that is excellent advice and so powerful. Mm-hmm. And I just want to thank you so much for sharing all of this with us today. And thank you for being on our show.
Thank you. Thank you very much for asking me.
Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.